Dear colleagues, my name is Luca Hergár, and I would like to present to you my 6 months progress on my topic, translational key points between radiology, physical examination, and hand surgery. I'm a resident doctor at the Department of Orthopedics at Semmelweis University, and my vision is adequate diagnosis at the first doctor-patient interaction. My mission is to evaluate the accuracy of diagnostic methods in hand surgery. I'm currently working on 3 projects. The first one is about wrist MRI, and the 2 others are concerning 2-point discrimination. Let me present you my first project, investigating the diagnostic accuracy of magnetic resonance imaging for lesions around the wrist. Wrist soft tissue injuries are common pathologies. This can be in the background of nearly 1/4 of chronic traumatic pain. The current gold standard is arthroscopy for the diagnosis of wrist soft tissue lesions. And during the diagnostic procedure, we can also use wrist MRI. The aim of our study is to determine the diagnostic accuracy of MRI and also to find out what are the factors that might decrease or increase the diagnostic accuracy. Our hypothesis is that the diagnostic accuracy of MRI is close to arthroscopy, and that there are certain factors that can decrease or increase the diagnostic accuracy. During our search, we found 44 eligible articles, and we completed the data extraction. We focused on the sensitivity and specificity of the MRI for TFCC tears in general, and also separately for TFCC central and peripheral tears, as well as on scaphoulonate ligament tears, as you can see it on the picture. Finding the pathology causing wrist pain is important, but beside MRI, we also have clinical examination and patient history to help us. But what is really important for us is the specificity of this diagnostic method, as with a high specificity, we could limit the number of false positives, avoid unnecessary surgical intervention, and help an adequate preoperative preparation. We try to find the answer, is this a reliable diagnostic tool for clinical decision-making in the case of TFCC injury, scaphoulonate, and other ligamentous tears? I would like to present to you in details the results of TFCC injuries in general. Here you can see the forest plot of the studies that were included in this part. And you can see here the pooled sensitivity and specificity values. Although it's not equivalent to arthroscopy, in the clinical practice, we can say that this is high enough sensitivity and specificity, although it's difficult to say what's the exact cutoff value. Here you can also see a figure about the pooled sensitivity and specificity for the TFCC injuries, and for the publication bias we used the Deeks test. As here the p-value is over 0.05, we can declare that we didn't find any publication bias. To compare the results for the different tiers, what is interesting here, I think, is that when we looked separately the TFCC central and peripheral injuries, we found a higher sensitivity and specificity compared to the TFCC tiers in general. And for the scaphoulonate ligament injury, we found that although the sensitivity was a bit lower than for the TFCC, the specificity was nearly the same. The strength of our study is that we included a large number of studies, and the unit of our analysis was the injury, so we hope that this means that we managed to do a precise analysis. We also considered variable factors that might influence the results, but we need further analysis to find out what are the most important factors in the diagnostic accuracy. Our study was limited by the heterogeneity of studies. For the same kind of injuries, different authors used different kind of classifications, and sometimes we were also limited by poor data quality. In conclusion, we can say that investigating a precise type of injury leads to better sensitivity and specificity results in the case of TFCC tears. Also, the sensitivity of MRI for scaphoulonate ligament lesions is lower than for TFCC tears, but the specificity is similar. In clinical practice, we can say that MRI is a reliable method for diagnosing wrist ligament lesions, and the specificity is sufficiently high to help adequate preoperative planning. We hope that our meta-analyses will help to set up clinical guidelines for wrist MRI, and will encourage discussion between hand surgeon and radiologist. As well, it will play a part to reduce purely diagnostic surgical interventions. For further research, we advise precise documentation and the comparison of both technical and personal aspects of MRI imaging. My second project is about the correlation between two-point discrimination and electroneurography in carpal tunnel syndrome. We compared two-point discrimination values to the gold standard electroneurography in the assessment of sensory nerve function. The clinical implication of this study is the estimation of the severity of carpal tunnel syndrome during physical examination. We found significant results with two ENG variables between these two variables and the two-point discrimination. But unfortunately, the correlation is not very strong in these cases. So in conclusion, we can say that although there is a correlation between two-point discrimination and ENG, this is not strong enough for a definite diagnosis. And my third project is about the investigation of the effects of different conditions on two-point discrimination values, such as age, gender, pregnancy, cortical function, BMI, and laterality. Currently, we are after the automatic duplication removal, and we plan to move on with this project in the following weeks. An overview about my project: we plan to finish in the beginning of summer with these projects. So I would like to thank you for your attention with a quote from Antoine de Saint-Exupéry: "A goal without a plan is just a wish." Thank you very much.
Thank you for the presentation. I'd like to ask you regarding your first project. Like, is there a time frame where after the injury occurs, is there a time frame where you would look at the injury with an MRI, when this would be sensitive or specific enough, but after a certain period of time it wouldn't be a reliable method?
Thank you for your question. Normally, these injuries don't get worse during after a certain amount of time. So I would say that there is no exact time frame. Usually, what is happening in the clinical practice as well is that they do an MRI shortly after the injury when the patients have complaints, and if they don't see any big injuries, then they sometimes advise conservative treatment, and if the complaints don't disappear, then they do again an MRI. But there is no exact time frame for the sensitivity and specificity.
Thank you.
Congratulations, fantastic presentation. Actually, I think after regarding your first study, based on your presentation, from now on we have to think about the other question. When should we perform arthroscopy, diagnostic arthroscopy? I think now we are sure that MRIs should be the basic, and the next question then is when to perform arthroscopy, diagnostic arthroscopy. Do I know it right that you can perform also the intervention at the same time if during the diagnostic arthroscopy you see any problems?
No, of course you can perform at the same time or really shortly after the MRI imaging. The role of MRI imaging in this case would be to help the preoperative planning, because there are different interventions, also different kind of postoperative treatment. And with an MRI, if we know in advance the exact pathology, we can plan the surgery and we can inform the patient in advance. We can prepare the operating theater of what kind of material we need. So this is why we consider important the MRI imaging, and also that it would have a high specificity, so we would have bigger safety both for patients and operators. And as your question is when to perform arthroscopy, if there is a significant lesion, especially if it's a peripheral TFCC tear, an arthroscopy is advised, because that the circulation is quite well, so there is a possibility of reparation. Whether, for example, for central TFCC lesions, it's more like a cleaning that can be performed. It is not a really urgent intervention.
Congratulations. Just one question for the first topic. Would you trust, because you mentioned that the better the MRI machine, the specificity is higher. So would you be so brave and make a guideline that make these kinds of examination over a 3T Tesla MRI machine, or would you trust an MRI machine with 1.5 T?
So I think this is a very interesting question, and thank you very much for it. If you allow me to go back to the results, what I found interesting is that it was not the results were not that evident. So we compared the 1.5 Tesla to the 3 Tesla machines. For example, here the sensitivity was actually higher at the 1.5 Tesla machines compared to the 3 Tesla machines. There can be a number of reasons why is it like that. For example, for 1.5 Tesla, there were more studies included, and as we consulted the radiologist, he said a number of factors can play a role here. For example, is there an interslice gap, or which size is the interslice gap in the MRI imaging, whether the MRI imaging was evaluated by a musculoskeletal radiologist whose specialty is to evaluate these results, and what positions was the wrist during this examination. So during our research, we found that the answer is not as evident as it should be, but we try to define these factors the most precisely. Of course, we are limited by the heterogeneity, so this is why for further research we would suggest, for example, to do the different investigation with different technical aspects for the same patients, and this would be a more comparable study.